Hi and welcome back. So today we're going to talk about what does the research in psychopharmacology actually say. So psychopharmacology is often taught as if evidence is neutral and straightforward. Well, the fact of the matter is it's not. Now this lecture is going to be about how evidence is shaped before it ever reaches the patient, and how that shaping affects what you prescribe, what you expect, and what your patient experiences. Now, there are two forces that dominate psychiatric outcomes more than most clinicians realize, and they are who was or is studied and what people believe will happen. Who is studied and what people believe will happen. Now, if you misunderstand either one, you can practice perfectly and still get poor results. So the task today is going to be to learn how to read research with clinical judgment rather than deference. You want to be able to understand what the data actually supports, where it stops, and how to speak about it honestly without undermining care. Now here's the roadmap for today. We're going to start by looking at study populations and defining criteria, because every conclusion in a paper rests on who was allowed into the study and who was specifically kept out. Then we're going to contrast trial data with real-world data, and we're going to focus on the difference why efficacy does not nicely translate into clinical practice, that is, effectiveness. And then we're going to examine primary versus secondary outcomes, since many psychopharmacology claims are built on findings that the study was never designed to prove. People tend to overgeneralize and utilize those secondary findings. And then we're going to talk about statistical power and error, especially type 2 errors, which quietly shapes what you think doesn't work. Then we're going to talk about the concept of randomization and bias in studies, not as abstract concepts, but as practical safeguards against misleading conclusions. And then finally, we'll talk about placebo and nocebo effects, followed by a focused discussion about confidence intervals and effect size, and why psychiatry uses trial designs like the sequential parallel comparison design, SPCD, to manage expectancy, that is to say placebo effects. And everything in this lecture supports one core skill: being able to decide whether a study is meaningfully applicable to the patient in front of you, and to explain that decision clearly. Now this slide here is asking one question: why should a future prescriber like yourself care about research methods at all? Well, the short answer is that misreading a study doesn't just bother you academically, it shows up as poor clinical decisions. Now, if you misunderstand a trial's population, you may end up prescribing to someone who was never represented in that study that brought that drug to market. Now, if you overvalue a secondary outcome, you may expect benefits that the drug has never proven to deliver. And if you don't recognize weak statistical power, you may abandon treatments that actually help, or adopt ones that don't. So every one of those errors can look reasonable on paper and still lead to worse patient outcomes. And the same applies to exclusions. When a trial excludes suicidality, substance use, medical comorbidity, geriatrics, pregnant people, children, polypharmacy, right? And many psych trials do exclude those people, then the results are really conditional. They're not universal. So the practical question you should be asking is not, did the study show benefit? But rather, does this study meaningfully inform my prescribing decision for this particular patient? Now, primary outcomes matter more than secondary outcomes for that same reason. Primary outcomes are what the study was designed, powered, and tested to answer. Secondary outcomes are really observations, not promises. It's like, oh, look what else we noticed. Now, finally, randomization matters because without it, we can't tell whether the drug actually worked or whether the people receiving it were simply different to begin with. See, this slide is meant to be answered out loud. Well, don't do this in front of your patient, but in your mind and in academic settings when you're having these conversations. The purpose is to help you frame how you should be thinking every time you read a paper, say in Journal Club or on your own. Now let me spend some time here with the importance of inclusion and exclusion criteria. So everything in clinical trials rests on one foundational decision: who's allowed in. Inclusion and exclusion criteria don't just define the sample, they also define the limits of the conclusion. So psychiatric drug trials will often exclude things like active substance use, severe suicidality, trauma-related complexity, medical comorbidities, concurrent medications. Those exclusions reduce noise and improve the internal validity of the study, but they also then reduce the generalizability and narrow the applicability. So when a paper concludes that a medication is effective, what it really means is effective for patients who look like the study population. And this is why generalizability matters. The more selective the criteria, the less confidently you can apply the findings to complex real-world patients. Clinically, this should change how you think, not whether you prescribe, but how cautiously you interpret benefit and risk. Now, instead of assuming that the study predicts outcome, you should treat it as a starting point, not a guarantee. So if your patient is more complex than the study population, and most are, you should expect smaller benefits, more side effects, less predictability. That's not a failure of the medication, it's just the limitation of the evidence available. Now this slide is a change from who was studied to how results behave outside the study. So clinical trials are designed to measure efficacy. That means, does the drug work under ideal, tightly controlled conditions? But you, in clinical practice, are really concerned with effectiveness. That means, does the drug work in the real world? When people miss doses, stop early, combine substances, live under chronic stress, those are not the same question. Trial participants are usually carefully selected, closely monitored, motivated to adhere to the therapy, and sometimes removed from many real-world stressors. Real patients are not. So when real-world data fails to replicate trial results, that doesn't mean the trial was wrong. It means that the conditions changed. So for you as a prescriber, this distinction matters because efficacy tells you what is possible, but effectiveness tells you what is likely. Now, when a medication underperforms in practice, the correct response is not to dismiss the evidence, but to recognize the limits of what the evidence can promise. Well, what happens after you accept that trials and practice don't align perfectly? Clinical application always requires an adjustment. Patients will differ from trial participants in ways that matter, right? So you'll see greater diagnostic complexity, multiple comorbidities, prior treatment failures, concurrent medication uses. None of those invalidate the research, but they do change how cautiously you should interpret it. So when you apply study findings in practice, you're not reproducing the trial, you're translating it. And that translation involves modifying your expectations of benefit and more closely monitoring for side effects, and a willingness to accept a greater variability in response. This is also where treatment resistance appears, not because the medication doesn't work, but because the patient does not resemble the population in which the benefit was demonstrated. So your more nuanced prescribing means you have to hold both these truths at once. The evidence supports trying the medication, and the evidence cannot predict that this individual outcome is going to occur. One of the most common sources of misinterpretation in psychopharmacology research and research in general is every clinical trial is designed to answer one main question. That question is represented by the primary outcome. Primary outcomes are the pre-specified, before the study begins, used to calculate sample size and statistical power. And that's the basis for whether a trial is considered successful. Now, if the primary outcome is not met, the study is technically negative, regardless of what else looks promising. And the big problem in research is negative findings often do not get published. Secondary outcomes, on the other hand, are serving a different purpose. They help researchers explore patterns. They generate new hypotheses and they guide future studies. But these are not considered definitive evidence. The danger really arises when secondary outcomes are treated as if they were primary. And that's how weak evidence gets overstated and how clinical expectations get inflated. Clinically, the rule is simple. If a benefit appears only in a secondary outcome, you should interpret it as tentative, not established. That doesn't mean that the finding is meaningless, but it does mean that it should not drive your prescribing decisions on its own. So now I'm going to tie together statistical reasoning with clinical judgment. The concept of statistical significance answers a narrow question. Is this result unlikely to be due to chance? That's all. Statistical significance does not answer, is the effect meaningful to patients? It does not answer, is it worth the side effect burden? It does not answer, is it better than existing options? A drug can reach statistical significance with a very small effect size, especially in very large trials, and still offer minimal clinical value. So that's why effect size matters more than the p-value for prescribing decisions. Now, research errors compound this problem. So a type 1 error, also known as a false positive, can lead clinicians to prescribe medications that don't meaningfully help. A type 2 error, known as a false negative, can cause us to dismiss treatments that actually work for some patients, and patient expectations further shape that outcome. So things like belief and trust and framing can amplify benefit or create harm through a nocebo effect. So what you say when starting a medication becomes part of the intervention. So if you carelessly frame, then you can worsen side effects. You need to thoughtfully frame, and you can actually end up improving adherence and outcomes without deceiving the patient. So finally, when a study shows statistically significant but small improvements, the real question is not, should I prescribe this? It's for whom, under what conditions, and compared to what alternatives. That's the question that keeps your prescribing grounded in evidence-based practice. Now, this table is here to make the abstract distinction between primary and secondary outcomes a little more concrete. Let's take, for example, a typical selective serotonin inhibitor trial, right? It's for depressive symptom reduction. This is always it's almost always the primary outcome. Now, that is the outcome that the trial is powered to detect, and the one regulatory approval hinges on. Other domains like sleep quality, functional status, sometimes anxiety, those are often secondary outcomes. They're measured, but the study is not designed to prove changes in those areas. So notice the row where anxiety appears as both a primary and secondary outcome. That reflects a common reality. Some trials are designed specifically for anxiety disorders, while others measure anxiety as an exploratory add-on. You see, that key point is this: the same symptom can be primary in one study and secondary in another. So you can't assume that an outcome is proven simply because it was measured. When a clinician says, this medication helps sleep, the correct follow-up question is, was sleep a primary outcome or merely observed? So this table is not about memorizing categories, it's just learning to locate where confidence ends and where inference begins. So what is statistical power? You've heard me reference this before. So statistical power refers to a study's ability to detect a true effect if one actually exists. Statistical power refers to a study's ability to detect a true effect if one actually exists. So conceptually, power is determined by four things. The four things that determine the power of the study, the statistical power, are sample size, effect size, variability, and the chosen significance threshold. So they will choose small, medium, or large effect before this study goes forth. It's chosen by the investigator. Now, sample size matters because larger samples reduce random noise and make real effects easier to detect. Effect size matters because very small effects require a much larger sample in order to be reliably detected. In psychiatry, effect sizes are often modest, which means underpowered studies are common. Variability matters because the more heterogeneous the population, the harder it is to detect a consistent change. Also, psychiatric symptoms vary widely between individuals, which further challenges the power of a study. And finally, the significance threshold, typically set for a p-value of 0.05, sets how strict the study is about calling a result real. The smaller that number, the more strict it becomes. Stricter thresholds reduce false positives, but increase the risk of false negatives. Power calculations are done before the study begins, and they reflect what the researchers believe is a clinically meaningful difference worth detecting. Clinically, this means a negative study does not always mean the drug is ineffective. It may mean that the study was not designed to detect the size of the effect that actually exists. So understanding power protects you from prematurely dismissing treatments and also from over-interpreting null results. Let's talk about randomization. So randomization is often described as the gold standard in clinical trials, but it's important to understand what problem it actually solves. So randomization improves internal validity. So what's internal validity? Well, internal validity refers to how confident we are that the outcomes observed in a study were caused by the intervention being tested, rather than by some other factor. It does this by reducing selection bias. And what is selection bias? Well, selection bias occurs when the people who receive a treatment differ in systematic ways from those who do not. So randomization assigns participants to groups by chance, not by choice. And this helps distribute the confounding variables evenly across the groups. So what's a confounding variable? Well, a confounding variable is any factor, measured or unmeasured, that could influence outcomes independently of the treatment. Now, some confounders are obvious, like baseline symptom severity. Others are a little more subtle, like what? Like motivation, like expectancy, or prior treatment experiences. Randomization does not eliminate these differences, but it does make them far less likely that they cluster into one group. So this is why randomization is sometimes called the great equalizer. Not because it creates identical groups, but because it makes the groups similar enough that differences in outcomes can reasonably be attributed to the intervention. Without randomization, we can't distinguish causation from coincidence. We may observe improvement, but we can't say with confidence why it occurred. Randomization strengthens study integrity by limiting alternative explanations for the results, and that allows researchers and clinicians to make these causal claims rather than simple associations. So clinically, this means that randomized trials deserve more confidence than observational studies. However, randomization does improve internal validity, not generalizability. You see, generalizability refers to how well the study findings apply to patients outside the study population. A study can be rigorously randomized and still poorly reflect the patients that you're actually seeing. So randomization helps answer the question, did the drug cause an effect? It does not answer for whom, under what conditions, and in what real-world settings will this effect actually occur. So let's say a study shows a drug reduces anxiety by 3 points with a 95% confidence interval of 0.5 to 5.5. That means we are 95% confident that the true effect is somewhere between 0.5 and 5.5. But that lower bound of 0.5 might not be meaningful to patients. So even though the average effect is statistically significant, the confidence interval shows that we can't be confident it's always clinically meaningful. We'll contrast that with, say, a confidence interval of 3 to 6. Now we know that the drug's effect is consistently in the range most patients might actually notice, and that's more reassuring. Confidence intervals also show us precision. Narrow intervals suggest we have a solid estimate. A wide interval says we think it helps, but we're not quite sure how much. So understanding confidence intervals helps us move from, is it significant, to, is it significant, and how confident can we be in the size of the effect? Now this slide is designed to compare randomized to non-randomized studies in terms of bias. The first thing I want you to clarify is these percentages shown are just conceptual. They're not real. They're not mathematical. They're just meant to illustrate relative risk of bias, not to quantify it precisely. Now let me define what I mean by bias. So in research, bias refers to any systematic error that distorts the relationship between an intervention and an outcome. Now, one of the most important forms is selection bias. Selection bias occurs when the people who receive a treatment differ in a meaningful way from those who do not. So before the treatment ever starts, randomized studies tend to have less selection bias because assignment to treatment groups is determined by chance rather than by some clinical judgment or patient preference or illness severity. That doesn't mean randomized studies are bias-free. It just means that they're less vulnerable to certain predictable distortions. Whereas non-randomized studies, such as observational studies or registry data, like big data analysis, they carry a higher risk of selection bias because treatment decisions are influenced by real-world factors. Symptom severity, access to care, clinician preference, patient motivation. Those factors can influence outcomes independently of, say, the medication itself. Clinically, this distinction matters when interpreting results because findings from randomized trials will support a causal inference, the conclusion that the drug likely caused the observed effect. Now, findings from non-randomized studies support association, not causation. They can suggest patterns, generate new hypotheses, and they actually reflect real-world use, but they require more caution because the key takeaway is not one type of study is good and the other is bad. It's that different designs answer different questions, and your confidence in the conclusion should match the level of bias the design can reasonably control. This section introduces research errors, not as an abstract statistical mistake, but as predictable ways studies can mislead clinicians. So, in this context, a research error refers to a systematic mistake in how results are generated, interpreted, or applied that leads to incorrect clinical conclusions. Now, some errors make treatments look effective when they are not, and others hide real effects that actually matter. What's important to understand is that these errors are not rare, and they are not signs of bad science. They're just inherent risks in studying complex human behavior and symptoms. So in psychiatry, where outcomes are subjective, effect sizes are small, and placebo response is high, research errors have outsized clinical consequences. The next slides will walk you through the main types of errors step by step. The goal is not to memorize terminology, but to recognize patterns of failure that should make you pause before accepting any conclusion. So if you can identify how a study might be wrong, you're far less likely to be confidently misled by it. A predictable way that studies can often mislead when you're reading them. So a type 1 error occurs when a study concludes that a treatment is effective when it is not. In other words, you're getting what they call a false positive finding. Statistically, this means that the study detects an effect that does not truly exist in the population. Clinically, this means we believe a medication works when it actually doesn't. Well, type 1 errors are closely tied to that statistical significance threshold. So most commonly a p-value of less than 0.05. That threshold represents accepted risk of being wrong about 5% of the time. So even a well-designed study will occasionally produce false positives. That's not a flaw, that's a trade-off. Like everything in life, it's trade-offs. The danger comes when statistically significant findings are over-interpreted. So a type 1 error can occur when, say, the effect sizes are very small, or multiple outcomes are tested without proper correction, or secondary outcomes are treated like primary outcomes, right? Or results are selectively reported or emphasized. All of those are false positives. Now in psychiatry, it's especially risky because modest symptom changes can reach statistical significance without really translating into meaningful clinical improvement. So clinically, the consequence of a type 1 error is over-treatment. So we may prescribe a medication and add side effects and cost and burden without providing for real benefit. And this is how ineffective or marginally effective treatments enter into routine practice. It's not fraud, but it's misplaced confidence. So understanding type 1 errors helps you stay cautious about positive findings, not just the negative ones. A statistically significant result is not a green light. It's just an invitation to look more closely. Now, a type 2 error, on the other hand, this occurs when a study fails to detect a real effect that actually exists. So in simple terms, it's a false negative. Statistically, this means that the study concludes that there is no difference between groups, when in reality there is one. Now, clinically, it means an effective treatment is going to be dismissed as ineffective. Type 2 errors are closely related to statistical power. Remember, power refers to a study's ability to detect a true effect when it exists. Low-powered studies are more likely to miss real treatment effects. Some common causes of type 2 errors include things like small sample size, high variability in symptom presentation, short study durations, outcomes that are difficult to measure reliably. And psychiatric research is particularly vulnerable to type 2 errors. Why? Well, because symptoms fluctuate and diagnoses are kind of heterogeneous. And effect sizes are often very modest to begin with. So clinically, the consequence of a type 2 error is going to be under-treatment. We may abandon useful medications and combinations and dosing strategies because the trials were underpowered to detect the benefit. So this helps explain why some treatments appear ineffective in early studies but prove useful in later, larger, or better designed trials. Type 2 errors remind us that a negative study does not automatically mean a treatment does not work. It may simply mean the study was not designed to detect the effect. And as clinicians, this is going to require some humility on your part, because the danger here is you assume that absence of evidence is proof of absence. It's not the same thing. Absence of evidence is not the same as evidence of absence. Well, there's a third type of error that doesn't get a lot of airtime, and it's called a type 3 error. And this occurs when study results are technically correct, but the reasoning applied to those results is wrong. In other words, we get the right answer to the wrong question, or we apply correct findings in an incorrect way. This is not a statistical failure, though. This is a conceptual failure. So unlike a type 1 error where we believe that something works when it does not, or a type 2 error where we miss a real effect, a type 3 error occurs during the interpretation and implementation. So the data may be sound and the statistics may be correct, but the conclusions drawn or the clinical actions taken are misguided. Now, in psychiatry, this often happens when group-level results are applied uncritically to individuals. Symptom reduction is assumed to equal functional improvement. Correlation is treated as causation. Mechanism is inferred without evidence. So type 3 errors are especially relevant today also because in the age of artificial intelligence and large language models, AI systems are very good at producing coherent, confident-sounding explanations. They summarize and generalize and connect ideas fluently, even when the underlying logic is flawed or oversimplified. Because, the output is only as good as the prompt, and it wants to agree with you. So this increases the likelihood of a type 3 error by encouraging overgeneralization from limited data and blurring the distinctions between statistical significance and clinical meaning, and presenting plausible narratives that are not evidence-based. So an AI tool can correctly summarize a trial and still promote your incorrect reasoning about why a drug works or who it helps or how it should be used. So for clinicians, this means the primary risk is no longer, is this result true? It's, am I reasoning correctly about what this result means? So avoiding a type 3 error requires clinical judgment, not just statistical literacy. It requires you asking whether conclusions make sense biologically, clinically, and ethically, not just whether they are well written. So in the age of AI, reasoning, not recall, is going to become the core professional skill. Look for the bonus video on AI prompt and consort reasoning towards clinical trials. Now let's talk about the placebo effect. This refers to measurable improvement in symptoms that occurs due to expectation or context and meaning, rather than actual pharmacologic action or treatment itself. This is not an imaginary improvement, by the way. This reflects a real neurobiological change, particularly in dopamine or endogenous opioids and stress response systems. So in research, placebo effects matter because they can inflate apparent treatment response. Now, if both the active drug and placebo groups improve substantially, the difference between them may be small, even when the medication has a real pharmacologic effect. This is one reason psychiatric trials often show modest effect sizes. They're not competing against nothing. They're competing against expectation, care, attention, hope. All that's called therapy. So clinically, placebo effects remind us that outcomes are shaped not only by the molecules, but by the therapeutic relationship and how treatments are framed, and the credibility of the clinician and the patient's prior experience. Placebo effects are value neutral. They can improve outcomes, but they can also distort the interpretation of efficacy. So understanding placebo effects help you read trials more carefully and practice more intensely. So placebo response is the individual patient's symptom change attributable to the mechanism. So the distinction matters because placebo effects refer to the phenomena at the group level. Placebo response refers to what happens within a given patient. In clinical care, we're not trying to use placebo deceptively, we're trying to ethically harness expectancy and meaning. So that includes a clear, confident explanation of why a treatment was chosen. It also includes setting realistic but hopeful expectations and avoiding language that primes them for fear or failure. See, this is especially relevant in psychiatry where outcomes are strongly influenced by attention and alliance and narrative coherence, and also by the patient's predisposed cognitive distortions and how they filter everything being said. So a placebo response also explains why sometimes early improvement does not always persist. Expectation-driven gains will fade out if not supported by real biological or behavioral changes. So for clinicians, the goal is balance. You want to respect the power of belief without mistaking it for pharmacology. So a good clinician is not relying on placebo, but you're designing a care environment that allows real treatment to work as well as possible. Well, contrast to placebo, now we'll talk about nocebo response. Now, nocebo response occurs when negative expectations lead to worsening symptoms or perceived side effects, independent of the treatment's pharmacologic action. So in other words, belief causes harm rather than benefit. Like placebo effects, nocebo responses produce real, measurable physiologic changes, and these often involve things like heightened anxiety, increased pain perception, activation of stress pathways. Nocebo responses are especially common in psychiatry because patients are often highly vigilant to internal sensations and they're usually anxious about medications to begin with. And they are influenced by prior negative experiences or online narratives. So importantly, nocebo responses do not mean that the patient is exaggerating or malingering. The symptoms are real. The cause is expectations. Clinically, nocebo effects can lead to early discontinuation of what would have been effective medication. Also, misattribution of common or unrelated symptoms to treatment. Or nocebo can also lead to escalating fear that undermines the adherence. So how do you manage nocebo responses? Well, it does not mean withholding risk information. It means how information is delivered matters. So for example, framing the side effects as possible but uncommon rather than expected, normalizing transient adjustment symptoms. Explaining which symptoms require attention and which usually pass. This will allow clinicians to remain honest without unintentionally priming the patient for expected harm. Recognizing nocebo response is a professional responsibility because it protects the patient from unnecessary suffering, and the goal is to preserve that therapeutic alliance. In modern practice, especially in the age of online forums and AI-generated health content, fear spreads way faster than evidence. So clinicians are going to have to actively counter misinformation with clarity, calm, context, and humility. And good prescribing is not about just choosing the right drug, it's also going to be about shaping the expectations so that real treatments will have a fair chance to work. This slide's going to move us from theory to practice. So everything we've discussed, placebo effects, nocebo effects, statistical interpretation, ultimately shows up in how clinicians communicate and frame treatments. So let's walk through each strategy. So patient education doesn't mean overwhelming the patient with data. It means providing clear, structured, and relevant information. Patients will do better when they understand what the medication is targeting, what improvement typically looks like, and what symptoms are common, and what early adjustments versus true adverse effects look like. Clarity reduces uncertainty, and uncertainty tends to fuel nocebo responses. Now, positive reinforcement, this is not cheerleading, this is reinforcing realistic progress and effort. So statements like, this medication tends to help gradually over a few weeks, or what you're noticing so far is consistent with early responses. What you want to do is support engagement without promising outcomes, because this enhances placebo effects ethically, and by supporting the belief without deception. Expectation management is crucial, and this is where many clinicians struggle. Patients deserve honesty about risks, but timing, framing, and context matter. Discussing benefits and risks together, rather than leading with the side effects. This will prevent fear from dominating the narrative. The goal is not optimism or pessimism. The goal is calibrated realism. And obviously we have to build a therapeutic alliance because this is the primary driver of a successful outcome, and it ties everything together. A strong alliance increases adherence and tolerability and persistence, even when side effects or uncertainty arise. Patients are more willing to tolerate discomfort when they trust that you are monitoring carefully, when you will adjust if needed, and that they are not alone in the process. At the system level, these strategies reduce things like premature discontinuation and unnecessary medication switches and misattribution of symptoms. At the professional level, they distinguish expert clinicians from people that are doing checklist psychiatry. Good psychopharmacology is not just about knowing the literature. It's about translating evidence into care so that patients can actually tolerate and trust and sustain. So this slide introduces confidence interval, which I talked about previously, but let me drive home this. Confidence intervals, which is one of the most underused but clinically useful tools in research interpretation. So a confidence interval is a range of values within which the true effect of the treatment is likely to fall, based on the sample studied. So conceptually, it answers a different question than the p-value. You know, the p-value asked, is this result unlikely to be due to chance alone? A confidence interval asks, how big might the effect actually be, and how precise is our estimate? That's the distinction that matters clinically. A study can have a statistically significant p-value and still be clinically unimpressive. So for example, a medication may reduce depression scale score by 1 or 2 points. That's statistically real. But functionally in a patient, that's meaningless. Confidence intervals makes this visible to you. A narrow confidence interval suggests more precision. It tells us the effect size is consistently small or consistently large across the likely range. A wide confidence interval signals uncertainty. The true effect could be trivial or meaningful or even negligible. This often reflects small sample sizes, high variability, and noisy outcome measures. So from a prescribing standpoint, confidence intervals help you answer, how confident should I be in what this drug actually does? Is the best case scenario clinically worthwhile? Is the worst case scenario still acceptable given risks and alternatives? This is especially important in psychiatry, where effect sizes are often modest and placebo response is often high. So when learning this or explaining research to patients, this framing shifts. We're not asking, does it work? We're asking, how much does it work? And for whom? So you want to look at confidence intervals before you look at p-values when you read a study. They tell you whether a statistically significant result is also worth acting on. Now, what do I mean about effect size? Well, this answers the most clinically important question in research interpretation. How much difference does this treatment actually make? An effect size is the quantitative estimate of the magnitude of a treatment's impact. Unlike the p-value, it's not about probability or chance. It's about clinical magnitude. So in plain terms, the p-value tells you whether effect exists. Effect size tells you how big that effect is. The distinction is critical in psychiatry because many psychopharmacology trials are statistically significant because they enroll large numbers of patients. But large samples can detect very small differences. Differences that may not even translate into meaningful symptom relief. They may not even lead to functional improvement or quality of life change. So effect size helps you judge whether a statistically significant result is trivial or modest or, clinically meaningful. So for example, you have two antidepressants and both work statistically, but one may produce a small average symptom change, while the other produces a change large enough that patients actually notice a difference in daily functioning. From a prescribing standpoint, effect size helps you weigh benefit versus side effect burden, medication versus psychotherapy, medication versus watchful waiting or supportive care. Effect size is also what allows you to compare studies meaningfully. So even when they use different scales or outcome measures, students or explaining treatment to patients, this framing will shift. We're not saying this medication works. We are saying, on average, this medication produces a small, moderate, or large improvement, and here's what that usually looks like in real life. So clinically, you want to integrate effect size, confidence interval, and patient context. Don't anchor your decision on the p-value alone. Effect size is where research evidence meets your clinical judgment. So this slide explains why modern psychiatric trials often look complicated and why that complexity unfortunately has to exist. So sequential parallel comparison design. This was developed in response to real problems that occur in psychopharmacology research, and that is specifically placebo response rates became so high that true drug effects were being washed out. Many antidepressants and anxiety trials have placebo response rates that exceed 30 to 40%, or show you, your drugs are as effective as M&Ms essentially. That makes it statistically difficult to detect whether a medication has a true effect beyond expectation, therapeutic contact, and time. So this SPCD comparison design trial is essentially a damage control strategy. The way this is done is first, a placebo lead-in phase identifies patients who respond strongly to placebo alone. Now those patients are not ignored, they're just handled differently in the second phase so they don't overwhelm the signal. Second, the sequential re-randomization allows researchers to compare outcomes across phases. That preserves the statistical power even when the placebo response is high. And then third, off-site raters are often used to reduce subtle expectancy bias that can creep in when clinicians know the trial structure or become emotionally invested in the outcome. So the goal here is not to trick patients. The goal is to separate belief effects from actual pharmacologic effects as cleanly as possible. Now clinically this matters because a positive SPCD trial suggests that a drug worked despite strong placebo pressure. A negative SPCD trial suggests that the medication likely adds little beyond expectation and support. So this also explains why some medications show modest effect size, but still clear statistical separation. They're being tested in extremely placebo-sensitive environments. So SPCD doesn't make a drug better, it just makes the evidence more honest. So this is why we cannot read psych trials the same way you would read a cardiology trial. The mind is never neutral to the measurement instrument. All right, so this is the moment where statistics stop being academic and start becoming more clinically applicable. So imagine a study shows a statistically significant reduction in symptoms, but the effect size is small. That does not automatically mean the drug is useless, and it does not automatically mean you should prescribe it. The first question is precision. Confidence intervals tell us whether that small effect is reliably small or whether the estimate is unstable and could plausibly approach zero. Next comes comparison. So is this drug meaningfully better than what we already have? If efficacy is similar but tolerability is worse, the answer may already be no. Then we weigh risk versus benefit. A small benefit can still matter if the risk is minimal. But a modest effect paired with weight gain, sedation, QT prolongation, metabolic harm, that changes the equation entirely. So now we have to individualize to the patient. Now some patients benefit disproportionately from modest effects, especially when options are limited or prior treatments have failed. Others are going to experience little benefit and substantial burden. So finally, we have to integrate the study itself. Who is included? Who was excluded? And how closely does this population resemble the patient sitting in front of you? This is not about finding the right answer. It's about making a defensible, transparent, patient-centered decision and being able to explain it. And this is exactly where AI summaries can mislead you, because statistically significant sounds like a recommendation when it's not. Large language models are very good at identifying statistical significance, but they're much less reliable about judging clinical relevance. So an AI summary may tell you that a medication significantly reduced symptoms, but it does not feel the difference between a 2-point change on a rating scale and a meaningful improvement in a patient's life. Now this slide shows the full translation pathway from research to bedside. So we start with research evaluation, and that's where we ask whether the study was well designed, adequately powered, and asking the right question in the first place. And then next comes statistical analysis. And this is where significance, confidence intervals, and effect sizes live. This is important, but it's not where the decision is made. The pivot happens at the point of clinical relevance. A small effect size usually means that the average symptom improvement is modest. In practical terms, this often translates to a high number needed to treat. So many patients may be treated for one to meaningfully benefit. Number needed to treat is how many patients need to be treated for one patient to meaningfully benefit. And that's where people get tripped up. A small effect size does not mean never prescribe. It just means be selective. And now we move to patient considerations. Now is this patient treatment resistant or refractory? Have they exhausted first line and second line options? Now for some with limited alternatives, even modest probability of benefit may matter. And then we look at the risk-benefit analysis. So if the number needed to harm is high, meaning serious adverse effects are uncommon, a small benefit may still be worth it and acceptable. But if harms are frequent and cumulative or long-term, then that same effect size becomes far less defensible. And then finally, we get to the point of the final decision. This is not a statistical conclusion, it's a clinical one. It integrates evidence, alternatives, patient values, tolerability, and risk. The key takeaway is statistics will inform the decision, but they can't make it for you. Your job is going to be to decide when a small effect is still worth pursuing, and to be able to explain that reasoning clearly to the patient in front of you. All right, let's pull this all together. So the core message of this lecture has been that critical appraisal is a clinical skill, not just an academic exercise. And good prescribing depends on your ability to evaluate evidence before it ever reaches the chart. First, study populations matter. If the trial population does not resemble your patient by age, comorbidity, burden of symptoms, severity of illness, and exclusion criteria, then the applicability of the findings is already limited. Second, primary outcomes matter more than secondary outcomes. Pre-specified primary endpoints are what trials are powered to detect. Post hoc or secondary findings may be hypothesis generating, but they're not the same as evidence for action. Third, randomization and study design matter. Randomization reduces bias, but it does not eliminate it. So you still need to assess internal validity, confounding variables, attrition, and measurement quality. Next, statistical rigor is essential, but it's not sufficient. Understanding things like sample size, power, and effect size tell you how reliable a result is, not whether it's worth acting on. This is where we made the key distinction between statistical significance not being the same as clinical relevance. A p-value tells you something happened. Effect size and confidence intervals tell you how much and how certain that effect really is. And we also address some common interpretation error, type 1, type 2, and type 3, because getting the wrong answer, missing the right one, or answering the wrong question all lead to poor care in different ways. And then we move beyond the numbers to the people, and we discuss placebo and nocebo effects, and they're not noise, they're part of the treatment. So patient expectations, framing, and the therapeutic alliance meaningfully influence outcomes and adherence. And finally, we return to the clinician's role. Clinical decision-making is multifactorial, as you have seen. You need to consider benefit versus harm, effect size versus tolerability, number needed to treat against number needed to harm, new treatments against existing options, a study population against the patient sitting in front of you. There is rarely a single correct answer, but there is a defensible, transparent, patient-centered one. And that, more than memorizing statistics, is the skill you are to build. Now this final slide is about how you should be using artificial intelligence, not whether you should be using it. AI is very good at summarizing research. It's much less reliable at interpreting research unless you force it to reason. Left on its own, AI models will often overweight statistical significance, and they'll underemphasize effect size, and they will typically ignore confidence intervals and flatten uncertainty and quietly assume that a published article means it's actionable. That's not a flaw, it's a reflection of how language models work. Your job is to prompt it like a clinician, not like a search engine. So instead of asking, is this drug effective, where might this study be vulnerable to type 1, type 2, and type 3 error? Does the effect size justify clinical use given the adverse effect profile? What assumptions does this study make about patient selection and adherence? How would these findings change or not change care for a treatment-resistant patient. You see what's happening here? You're not asking AI for conclusions. You're asking it to stress test the evidence. This is especially important now because AI summaries often convert statistically significant and under-controlled conditions into recommended. And that jump is exactly where poor prescribing happens. So if you use it well, AI can surface the blind spots and reframe the statistics into clinical language and help you explain uncertainty to patients and accelerate learning. But if you use it poorly, it can amplify type 3 errors and create false confidence and obscure nuance behind fluent language. So the takeaway is this: AI should make your thinking sharper, not shorter. It gives you answers without friction. You're probably using it wrong. If AI gives you answers without friction, you're probably using it wrong. And this is how you're going to future-proof your clinical reasoning in an AI-saturated environment. You need to stay the one who asks the right questions, because the answers will keep changing.